Good morning, everyone. Welcome back to Surgery Forum. Today, we'll discuss a bit about the risk factors that are involved in the development of pancreatic ductal adenocarcinomas. Let's get into it. What is a genetic mutation that confers increased risk of pancreatic cancer in Jews of Ashkenazi heritage? P53, P16, BRCA2, MSH2. We all know that Ashkenazi Jews are associated with increased risk of multiple malignancies, including pancreatic cancer. And the genetic mutation responsible is BRCA2. The BRCA2, mainly the deletion of the 6174 deletion T mutation, is seen in 1% of the Ashkenazi Jews. It is approximately 4% of all pancreatic ductal adenocarcinomas associated with this population. BRCA1 mutation, that is 185 deletion AG and 5384 insertion C, is found at 1%. So the most commonly associated is the BRCA2 followed by BRCA1. The following race or ethnic factors increase risk for pancreatic cancer except African American, Native Hawaiians, Ashkenazi Jews, or Asian population. The answer is Asian population. Asians have got a lower incidence of pancreatic cancer as compared to the other populations. Increased risk for pancreatic cancer is seen with all except cirrhosis, diabetes, H. pylori infection, periodontal disease. None. Now, this is a tricky question. Naturally, cirrhosis, diabetes, H. pylori infection, these we can assume to be having some relation with the GI tract and pancreatic cancer. But periodontal disease, and naturally, people will try to choose that, but the answer is none. There is some association between periodontal disease and pancreatic cancer based upon population studies. These are the various risk factors for pancreatic cancer. Let's go it one by one. Cigarette smoking. Yes, there is an increased risk for pancreatic cancer with cigarette smoking of the tune that nearly 35% of all pancreatic cancer is associated with a risk of cigarette smoking. There is a dose response relationship, and it is seen that if you have stopped smoking for more than 13 years, the risk of getting pancreatic cancer is equivalent to that of a non smoker. Similarly, environmental tobacco exposure, that is secondhand smoking, also has got a risk. Alcohol. Alcohol is seen as a risk, but whether or not it is a proper risk is still controversial. Alcohol can produce pancreatitis, leading to chronic pancreatitis, cirrhosis, and can result in pancreatic cancer. Residential radon is also a risk factor. Regarding the ethnic factors, African American men has got the highest risk factor for pancreatic cancer, followed by African American women. Natives of the female Native Hawaiians as well as Ashkenazi Jews have got a higher risk. So highest risk is seen with African American men. Dietary factors also have got an important role. High cholesterol, overweight, obese patients have got a higher chance of pancreatic cancer. The possible reasons that I mentioned include that increased intake of high fat cholesterol diet leads to obesity and metabolic syndrome and insulin resistance, which leads to increased insulin, and the trophic effect of the insulin and insulin-like growth factor result in formation of pancreatic cancer. Another hypothesis of the high-fat diet is that it results in absorption of more fat-soluble carcinogens in the food. So these are the reasons why high-fat diet is supposedly supposed to increase the risk of pancreatic cancer. Occasional, occupational exposure to carcinogens like asbestos, naphthalene, benzene, gasoline products, paramino, polycyclic aromatic hydrocarbons, etc., is also seen. Now, some hereditary predispositions are also there, including hereditary pancreatitis, HNPCC, breast and ovarian cancer, familial atypical multiple mole melanoma syndrome. We mentioned about the linkage gene with regard to familial atypical multiple pole melanoma syndrome in our previous lecture. Peutz-Jeghers syndrome, ataxia telangiectasia, Fanconi anemia, cystic fibrosis, etc. are inherited predispositions. And the medical conditions, chronic pancreatitis, cirrhosis, diabetes, H. pylori infection, and periodontal disease comes under it. There's an interesting correlation between height. It is seen that people who are tall have got a higher chance of pancreatic cancer. This might be because of a genetic correlation, but further details are not known. And the presence of a previous surgery, cholecystectomy and gastrectomy, as association to pancreatic cancer is being described. With regard to cholecystectomy, it might be because the occult pancreatic cancer might have presented with pain which was misunderstood to be because of a gallbladder etiology, and the patient might have underwent cholecystectomy. But there is also an increased incidence of pancreatic cancer in patients who have undergone cholecystectomy more than 20 years ago. So the exact reason behind is not known. Another aspect is that which blood group is not associated with pancreatic cancer? A, B, AB, O. So it's about which blood group which is not associated with pancreatic cancer. Answer is O. There is association studies which shows increased risk of pancreatic cancer in A, B, and AB blood group. And this risk is attributed to a single nucleotide polymorphism RS505922. The thing is that our blood group is seen in more than 50% of the population, and the association is not that strong. But the proportion of pancreatic ductal adenocarcinoma based upon statistical analysis that is attributable to a non-O blood group is 13 to 90 percentage. It is just to be remembered just in case it's asked. All of the following are associated with risk of pancreatic cancer except. Now we are coming to the familial or the inherited risk factors for pancreatic cancer. Hereditary pancreatitis, hereditary non-polyposis colorectal cancer, hereditary breast and ovarian cancer, familial atypical multiple mole melanoma syndrome, familial adenomatous polyposis. If we straight away look at this, all of them seem as risk factors for pancreatic cancer. But the trick here is that among these, familial adenomatous polyposis, this is not an established risk factor for pancreatic cancer. Yes, there is duodenal and periampullary adenoma and possible of periampullary malignancy seen, but the association with pancreatic cancer per se, it is not as strong as with the other risk factors. So the correct answer in this situation would be FAP. Highest risk for pancreatic cancer is seen with hereditary pancreatitis, hereditary non-polyposis colorectal cancer, hereditary breast and ovarian cancer, familial atypical multiple mole melanoma syndrome, Peutz-Jeghers syndrome. This is with regard to the relative risk of developing pancreatic cancer in this population, and the highest risk is seen with Peutz-Jeghers syndrome. The highest risk for pancreatic cancer is seen with which mutation? PRSS1, STK11, LKB1, MSH2, BRCA2, P16. This is a spin-off of the previous question. Actually, what this question tries to attempt is to have an understanding to see whether the candidate has got an understanding of the various genetic mutations in the hereditary syndromes. The answer is STK11, LKB1. So the PRSS1, it is actually the gene that is associated with hereditary pancreatitis. STK11LKB1, that is the gene associated with Peutz-Jeghers syndrome. MSH2, associated with the Lynch syndrome. BRCA2, associated with breast and ovarian cancer. P16, as previously discussed in the previous lecture, it is associated with familial atypical multiple mole melanoma syndrome. So this is a table of the relative risk of pancreatic cancer as well as the various genetic mutations seen in genetic syndromes. So this is, see, Peutz-Jeghers syndrome associated with STK11. It is seen in nearly 100 times the risk of pancreatic cancer is seen. Other ones like ataxia telangiectasia, Lynch 2 variant, they got a undefined incidence. If you want to look at the stratification, the highest risk is seen with Peutz-Jeghers. This is followed by hereditary pancreatitis, followed by familial atypical multiple melanoma syndrome, followed by hereditary breast and ovarian cancer. In that also, BRCA2 has got a higher risk, followed by BRCA1. And FAP is associated with periampullary malignancies. Some reports of pancreatic cancer is seen, but no genetic per se relation is noted with FAP. Thank you. All of you, please do like and subscribe the channel and look out for more videos. Try to share with your friends so that everyone will be benefited. And let me know your feedback if you have one. Thank you.